Funding for This Is Nashville comes from you, our listeners, and Alliance Bernstein. Since 2019, employees have impacted our community by giving more than 5,000 hours of volunteerism in Middle Tennessee. AllianceBernstein.com. Alliance Bernstein is not affiliated with National Public Radio.
I'm Khalil A. Colonna, and this is Nashville. This is a re-air of my conversation with Dr. Stephen Loyd. He's currently the Chief Medical Officer of Cedar Recovery and the Chairman of the Tennessee Opioid Abatement Council. Later on in the show, we'll give you some updated stats and info since this interview originally aired. But right now, let's get into it. So, Dr. Loyd wasn't always a supporter of harm reduction, but after surviving his own addiction, he's come to be one of Tennessee's greatest supporters of the practice. So what exactly is harm reduction? What are the rules in our state? And how does legislation come into play? To answer those questions, I'm joined by Dr. Stephen Loyd. Stephen, welcome to This Is Nashville.
Thanks, Khalil. It's great to be here.
It's really great to have you. So let's start off with the biggest question. What is harm reduction?
As simple as I can make it, it's about keeping people alive. And so I loved your intro because it was so true. I was not always a harm reductionist, but when you start to look at medicine in general and so-called real diseases like high blood pressure, diabetes, various other disease processes, it's all harm reduction. We don't cure the underlying disorder. We treat it, right? And we try to prevent the bad outcomes, the bad sequela. So I always use diabetes as the example. We don't cure people with diabetes for the most part. Diet, exercise, and then medication. And what we're trying to do is prevent the bad things that happen as a result of diabetes. We're trying to prevent vascular disease, heart attack, stroke, nerve disease, nerve pain, neuropathies, blindness, kidney disease. And if we keep it under good enough control, we can keep these bad things from happening for a longer period of time. It's all harm reduction. And so when I talk about harm reduction and what we're looking at in substance use disorder, it's about, it's not about total abstinence. There's a lot of folks out there that think, well, the only time that it's successful is when you're totally abstinent, right? The chemical is out of your life all the way around, and your drug screens don't have anything in them. And if that's going to be your only outcome that's acceptable, it's going to be a very tough road to hoe because some people get there in different ways. And, so is it better to inject 1 gram of heroin per day? Is that better? Is better to inject 1 gram than 2? And my answer to that is yes, it is. And if we're working towards that end, then that's a really good thing. Harm reduction is about keeping people alive. And until they can get involved in a recovery process, it's going to carry them forward in their life. And that's as simple as, that's how I think of it. I'm sure other people have more formal definitions.
In my research for our conversation, I learned that there's 4 pillars used: prevention, harm reduction, treatment, and enforcement. Right. How do those pillars work with each other?
That's a good question. Not very well a lot of times, particularly when you look at the enforcement arm of it, and our colleagues and peers in law enforcement that we need at the table, and a lot of times work very well together, but harm reduction is one of those 4 pillars, and I'm glad to see it in there. And Khalil, just your and I's conversation before we got started here today and what we've done previously in our life, we will bend the curve on this when we start looking more seriously at prevention, start looking at early childhood interventions and your past life, in addressing adverse childhood experiences of these kids that are growing up in households where pretty severe abuse is taking place, either physical, sexual, or emotional. And so I love the prevention arm of it, but we almost never talk about it. The treatment arm is after the disease has already taken hold and giving people access to treatment. That's another story altogether, because then you get into, what is effective treatment? Does it have to be abstinence-based? Can you use medication? And I am a huge medication guy for the simple reason is I've got to keep people alive. And then, the harm reduction part of that is just where it all starts. Okay, that is where it starts. We have to be able to keep people alive. We have to keep them from overdosing before we can ever hope to get them into a treatment program and help them build a life that they're going to enjoy going forward.
Now, you mentioned this a little bit, but I want to ask you a little bit more about harm reduction and how it's different from abstinence-based treatment. Right. Is that a professional scientific thing, or is that kind of philosophical?
Well, I would think that it should be a professional scientific thing. But if you look at the treatment world out there around substance use, it's the Wild West. All right. Most people who got into the field, like me, right? You've already said it. I got into this field because of my own substance use. And I wasn't interested in this in medical school or residency. And I got interested in it because of what happened with me. And so a lot of people who get into this field, Khalil, think the only way to get better is how they got better. And I actually did that early on. And after a period of time, I looked at, golly, I got better this way, but I had this resource, because I'm a doctor, right? I had access to care that the regular person doesn't have. And then I had to start to change my mindset. And my mindset today is this. My job is to help the person in front of me find the path to recovery that's right for them, not me. It may involve medication, it may not. It may involve abstinence, it may not. It may involve going somewhere, it may not. And so I've got to be able to set my own biases aside to be able to help my patient. And so it turns out to be a philosophical difference because you've got two different pathways out there that fight each other. You've got the folks who think everybody needs to be on medication or they can't get better, which is not true. And then you've got the abstinence-based folks saying if you're not on medication, then you're not in recovery. And that's dangerous ground to walk, Khalil. I lose patients every day to that one.
You talked about in medical school how this kind of wasn't taught. So harm reduction, or basically, addiction and substance use treatment isn't really taught in medical school.
No, very rarely. We're lucky enough to be here in Middle Tennessee, and we have two medical schools here. We have Meharry Medical College and Vanderbilt University Medical School, and actually in both of those, which I do teach, they are teaching that. They are addressing it. But nationwide, if you look at medical training in medical school and residency, it's very rarely touched upon. The proper prescribing of controlled substances for acute and chronic pain, which is how a lot of people get started in this, almost not touched on at all. So yeah, it's, and if you put COVID to the side, the number one health problem in the United States, I would argue, is addiction. And you say, well, that's not true. Well, let's bring in cigarettes, right? Let's bring in nicotine, and you start looking at, how many cases of heart disease are brought on by somebody smoking. I mean, it's huge. And most of our healthcare professionals out there delivering the care don't have basic understanding about addiction as the disease process that it is.
Tennessee's overdose deaths are up nearly 30% since the start of the pandemic. Yeah. And from 2016 to 2021, we saw those deaths more than double. Yeah. What's going on? Yeah,
the fentanyl. I came to Middle Tennessee from East Tennessee in 2015, 2016. And it was a different world then. We'd heard a little bit about fentanyl, but we knew as we shifted into the second phase of the opioid crisis from pain pills to heroin, I mean, that's kind of to be expected because heroin's cheap. It's available. People are desperate. We've cut down the supply of pills by a lot of things that we've done, education, shutting down some place, right, those type of things. But if you don't have proper treatment, the iron will, the market will happen, right? And so fentanyl, heroin we could kind of see. Fentanyl, I didn't see. The fentanyl I know about, Khalil, is fentanyl that you get out of the hospital, right? Patches and sprays and treatment for cancer. I didn't see illicit fentanyl made in labs brought into the United States and pressed into pills that looked just like the pain pills people were getting from pharmacies, and I certainly didn't see it adulterated with heroin.
How bad is this problem in our state?
It's a huge problem. I was talking yesterday, the numbers that the CDC came out for calendar year 2021, and we lost 107,622 Americans to drug overdose, and about 75 to 80% of those are fentanyl. If you put that in terms of a 747 crashing, okay, that's a 747 crashing every 36 hours. Now, I just met you, but I pretty well think if me and you knew that there was a 747 going down every 36 hours, we wouldn't get on an airplane.
Yeah, right? Yeah.
So it's huge numbers we're talking about here. But the problem is that they happen in isolation, right? It's not a 747 going down. It's this family in Clark Range, Tennessee, or this family in Memphis, Tennessee, and their loved one dies of addiction, and they don't want it outside the walls of their own house because of the stigma associated with it. And they won't even tell close groups like their Sunday school class or faith-based organization. So this is a huge problem. And the weird thing is that so much of it is preventable. And the other thing, Khalil, a lot of these are young folks, younger than you and I, who are losing, 20, 30, 40, 50 years of life. And I always looked at it this way. I'm an internist. I work in the hospital, ICU, and medical step-down units. If I put somebody on heart failure medication, I can give them 5 to 6 years of quality life, and that's not a bad thing. You talk about effectively intervening on somebody with a substance use disorder, you give them 50 years of life. You not only do that, you change the path of that family because their kids aren't raised in those environments. And that's why this gets so exciting for me and frustrating at the same time, as you can probably tell.
Is fentanyl kind of a recent phenomenon in our state? I mean, I can't remember anybody nationwide talking about fentanyl 10 years ago.
It's because of really there's, when you think of fentanyl, I want you to think of two different things, right? I want you to think of fentanyl that's prescribed in the hospital when people have surgeries, they have, end-of-life cancer care, palliative medicine. Okay, that's prescribed fentanyl. The fentanyl that you and I are talking about is really not that fentanyl that's been diverted, right? Taken out of the hospital. We're talking about fentanyl, powder fentanyl for the most part, that has been chemically made in a lab, like Breaking Bad, okay? Chemically made in a lab and then pressed into medication that looks like we get from the pharmacy, or adulterated in heroin or adulterated in methamphetamine, okay? Now, the issue is that one such fentanyl is called carfentanil. Carfentanil is made to anesthetize rhinoceroses, made by the Johnson & Johnson company. When a rhinoceros weighs tons, right?
Yeah,
you and I, weigh 200 pounds. So you're talking about taking a medication that is multiple times stronger than heroin and morphine. So carfentanil is anywhere from 500 to 10,000 times stronger than morphine. And you get a hold of 1 grain of that and ingest it unknowingly and you die. And that's the issue. So we're really talking about two different fentanyls. There's a fentanyl used medically in the hospital for a medically approved purpose, and then the fentanyl you and I are talking about for the most part is illicitly made fentanyl and illicitly consumed fentanyl that's coming from other countries and brought into the United States.
If you're just tuning in, this is Nashville, and I'm your host, Khalil Ekalona. My guest is Dr. Stephen Loyd. Now, Steve, we were just talking about the growing presence of fentanyl and how it's contributed to the rising number of overdoses here. Tennessee legislators recently voted to decriminalize at-home testing kits in most cases. Right. Why are fentanyl testing strips considered so controversial? Well,
they were considered paraphernalia for the longest time, and that's what this legislation essentially did, was carve out a place for it. And if it's used to detect, the presence of fentanyl, for the reason of avoiding it, then it's not considered paraphernalia. Clearly, I really struggle with some of these things and why they are, like syringe exchange programs, right? We know the benefits of that. You're from Baltimore, right outside of Baltimore. Look at the benefit of syringe exchange programs in the city of Baltimore with regards to hepatitis C and HIV rates. Yeah. It's phenomenal, right? You can't get that big a drop doing anything else. There should be no argument against that, but there is. And the argument is that by providing these things, you're somehow condoning its use, which is just not true. And I don't care what side of the aisle you're on, the numbers say that it's not true. So fentanyl strips are much in the same vein. What could be the harm in knowing whether or not you had fentanyl in something you may get ready to put in your body? So I will tell you what the reason is. So there are folks out there in the throes of their addiction that are actually seeking fentanyl. Okay? So if you are a heroin dealer here in Middle Tennessee and your heroin doesn't have fentanyl in it, and somebody is after the fentanyl because it's better, okay, and you got to remember, it's going to kill you. But when you're in the throes of addiction, you don't have insight, judgment, and empathy, right? The three things that you need to make decisions. You and I need that to make decisions every single day. Yeah. So you're after that. So you test the heroin that you're getting ready to buy. It doesn't have fentanyl in it, right? So you say, well, I'm not going to buy from you. I'm going to buy from this guy. Now the heroin dealer says, well, I got to have fentanyl in mind if I'm going to be competitive in the market. And so you could see how there would be a downside to that. So that when we're talking about these things, we always need to address all of it. We need to address the pros and the cons. And if the pros outweigh the cons, then we need to be seriously looking at it. And in this case, the pros do outweigh the cons.
Now, you mentioned syringe exchange. I want to get to that.
Sure.
What is available here in Tennessee as far as syringe exchange?
We do have syringe services exchanges here in Tennessee. It's not widely available as I think it should be. I think it should be literally anywhere and everywhere. And we've got some wonderful folks and my friends here in Nashville at Streetworks that I love and do great work around that. But they will tell you it has to be in certain locations or certain rules around it, and it needs to be more widely available.
Why are the laws so restrictive?
I think stigma from addiction and the fact that you still in some way look at addiction as a moral failure, and by making these things available, you're condoning it.
What makes this work? What makes that work so complicated?
I think things that people bring along with them in their prejudice. And, we start talking about addiction and people ask me all the time, Steve, if you could have anything that you want to help in what we're addressing right now, what would it be? And it's not more money. although that's good. It's not more treatment centers. It's for people to open their mind and look at these folks as having a treatable medical condition and decreasing the stigma associated with it. Clearly, you can have the best treatment in the world, but if you don't have anybody step forward and ask for help, it don't matter. And so I think it's the stigma associated with how we have viewed addiction, particularly in the United States and more particularly the South, for literally, a couple hundred years.
I'm going to ask you a little bit more about that later on in the show.
Sure.
But, we talked about this earlier, this new law that allows doctors to offer an overdose reversal medication to anyone they write an opioid prescription for. I thought everyone in Tennessee already had open access to naloxone. What does this legislation here change?
This legislation gives doctors direction on it. So if you look at it, it's that you shall, the word shall is used in the legislation. That means you're going to do this, okay? And so if you write a prescription for an opioid for 3 days or more, okay, or you're writing a prescription for an opioid and a benzodiazepine at the same time, so a benzodiazepine would be a drug like Valium, Xanax, Klonopin, Librium, or if you're dealing with a patient who is at high risk, maybe they have known substance use disorder and you're providing a prescription for an opioid, then you shall write this prescription for Narcan as well, naloxone. So that's what it does. It is pretty widely available. I hear things said about state agencies all the time that are negative, TennCare and the Department of Mental Health and Substance Abuse Services. These folks make care available to a marginalized population, and they do great work. And so these organizations have already done good work in getting these medications more widely available. This just kind of gives doctors direction. Hey, we think this is important. It's coming from your legislature. And I'm going to be honest with you. I'm not the biggest fan in the world of politicians practicing medicine. But there are some times where if you're not willingly doing it and it's for the public good, then it needs to happen.
So you see this as a step in the right direction?
I do. And I'll take some grief from that because I've got some buddies listening to this show right now who are not going to agree with that. But we've been encouraging it for a long time. And it's time to do something about it. And we can encourage you and we can educate you. But we get to a point where, okay, there's no debate here. Fentanyl saves lives. Not fentanyl. Naloxone saves lives. Narcan saves lives. We need to get it in the hands of the people who are at highest risk. And we need you to help us with it. Now, you haven't helped us with it. So we're going to help you help us with it. And I call it God, good orderly direction.
I like that. We're about to go to break, but first, let's get some updated stats from Dr. Loyd. He says currently we're losing about 8 Tennesseans daily to drug overdoses. That number was a little under 5 when this interview first aired last year. Nashville and Memphis are in the top 10 for most drug overdose deaths in metropolitan cities in the United States, and neither is as bad as Knoxville, which didn't meet the population threshold for the data set he's referring to. Nashville is number 2, y'all. On a bit of a more positive note, he says Tennessee is receiving about $1.1 billion over the next 18 years from lawsuits against the industry to abate the opioid tragedy, and that our General Assembly and governor have been supportive in policy changes increasing and expanding access to treatment. Finally, he says what's always on his mind is the need to understand the urgency of the issue. We have people dying across our state unnecessarily. The biggest issue continues to be the stigma, not money, although we have to have money. He says we have to embrace harm reduction and a supportive system of care combined with evidence-based prevention. And until we do, the issue's only going to get worse. When we come back, we're going to hear what harm reduction sounds like on the ground. Then we'll pick up our conversation with Dr. Stephen Loyd and dive more into his personal experience with addiction. So stay with us. This is Nashville.
Funding for This Is Nashville comes from you, our listeners, and Music City Prep Clinic, Nashville-based provider for PrEP, and offering comprehensive sexual health services in an environment designed to be safe, professional, and shame-free. Learn more at musiccityprep.org.
I'm Khalil A. Colonna, and this is Nashville. Peer support is a term you might hear in mental health, disease, harm reduction, and addiction recovery work. The idea is really just what it sounds like. Support provided by people who have been there, done that, and are walking the walk with others. There's an organization in Memphis really leaning into this approach with harm reduction. It's called A Better Way. The group is dedicated to keeping used syringes off the street and out of use. They also offer wound care and free HIV and Hep C testing. Most of all, though, they build relationships. Senior producer Tasha A.F. Lemley spent an evening with them to see what peer support looks like on the ground.
We have very few rules. It's, no judgment, no expectation. Those are the top two. And unfortunately, the third most and final rule is dead addicts don't recover. So everything we do here is trying to keep the addict alive.
Ron Boble started A Better Way after he lost his own son to an overdose. He wanted a way to keep other people's kids alive and as healthy as possible until if and when they're ready to enter treatment.
There's already a challenge for services. We don't have enough detox beds. We don't, so not always are they ready to go either. So in the meantime, we're doing our damnedest to make sure that we're following the policies of harm reduction. We want to give them a clean rig for every time that they're using.
Okay, so this is kind of a controversial piece of this sort of harm reduction work, but we'll save that nuanced discussion for another day. Still, this speaks to Ron's goal, keeping these folks alive and safe. And who better to do that than people who have been through this themselves?
And the magic that happens here when it gets going, you'll see the empathy that these people have on the other side of the table. Everybody on the other side of the table has lived experience, so that's the true magic of what we do.
Over 6 hours one Friday night, nearly 100 people cycled in and out of an abandoned Shoney's parking lot east of Memphis. About a dozen peer supporters are on hand to facilitate syringe exchange, tend to wounds, provide food, and generally support. Jennifer Dancy is one.
How do you identify?
Huh?
How do you identify?
It's awesome.
You can decline it.
Male.
What's your sexual preference?
Male.
Tonight she's helping CS. They only ask for initials here to maintain some anonymity. She's getting his used syringe count and seeing what else he might need tonight.
What have you used in the last 30 days?
Marijuana and methamphetamine.
How many times do you inject a day?
Maybe once or twice a day.
Jennifer offers HIV and hepatitis C testing. They talk over STD protection and fentanyl test strips. And as always, there's the offer of rehab.
Are you interested in treatment options at all?
No. Not today.
Okay, well, if you decide you want to talk about it, I have someone with lived experience, so I'm going to give you my card. You can call or text. I'm not going to push you to do anything, but we can go through all the options if you want to.
A couple minutes later, and they're both standing and embracing. CS breaks down. He's grieving over a newly incarcerated friend who he can't go see because of his own ongoing legal issues.
I haven't forgot about you. Everybody knows. I'm my friends. I just went to jail myself, so I got a case going on. And if I be having that case, it means I can't go see you no more.
CS says he hopes she knows he hasn't forgotten about her. He's just deep in his own stuff. He's facing drug possession charges that are likely a felony. Jennifer recommends drug court.
Because I'm a graduate, and even if it's a felony, when you graduate, it'll be expunged. And it's not as hard as people make it out to be. It's really not. They're really amazing people there.
So Jennifer knows from experience some of what CS is feeling. She's a survivor of addiction and incarceration, and she brings this experience to her work as a certified peer recovery specialist.
All of it is based off of what you go through while you're using. And that's the best way you can help somebody. So to have somebody say, hey, I know what it's like, and I've been through it, and here I am on the other side, it's different than having a physician or a psychiatrist try to help you, because how can, they can read a book, but they haven't been through it.
Let's take a short break. When we come back, Dr. Stephen Loyd gets deep into his own experience with addiction. Stay tuned. This is Nashville. I'm Khalil A. Colonna, and this is Nashville. We're talking this hour about harm reduction, something my guest has dedicated his life to. I've been visiting with Dr. Stephen Loyd, the Chief Medical Officer of Cedar Recovery and the Chairman of the Tennessee Opioid Abatement Council. He's become one of our state's leading advocates for harm reduction after his own personal experience led him there. Stephen, welcome back.
Thanks, Khalil.
So you've been very open about your battle with addiction. When did this battle begin for you?
It was in 2000, late 1990, early 2000, and I was already through medical school, and was in really the last part of my residency training in internal medicine, and was on my way home from work one day, and I'm not one of those, it was uphill both ways to school when I was a kid kind of guys. But we didn't have work hour restrictions back then. And so we routinely worked, 100 plus hours a week. And so I had a lot on me, tired, had a young family, and, personal life at the time wasn't the greatest in the world. And so I was on my way home from work one day and all those things building up on me. And I stopped at a red light. I was in East Tennessee at the time, my hometown of Jonesboro and Johnson City. And I flipped open the glove compartment of my truck, and there were some Norcos in there from a dental visit months before. I just threw them in the glove, didn't need them. And it's hydrocodone. And I looked at those and I said, my patients take these things all the time. And I pulled one out, broke it in half, threw it in my mouth. And by the time I got home, Khalil, 10, 15 minutes later, suddenly my life was livable. The depression wasn't as bad. My wife wasn't as bad. My kids weren't as bad. My job wasn't as bad. And I understood very little about addiction, almost nothing at all. I had no idea that my own underlying genetics and childhood trauma put me at risk. And so from that 2.5 milligrams of hydrocodone that day, it grew to 500 milligrams of OxyContin a day within 3 years. And if you think about that in the terms of Vicodin, right, which everybody understands what Vicodin is, Vicodin's 5 milligrams, so 500 milligrams would be 100 Vicodin pills a day. And at the end, before I got help here in Nashville, that was what I was doing. And I wasn't living under a bridge. I wasn't living on the street. I was a practicing physician in the hospital taking care of your relatives in the ICU, post-operatively, and in my office.
How are you getting this?
Oh, every which way you can think of. So this is a great opportunity to talk about some other harm reduction things. First place was out of people's medicine cabinets. So if I came into your house and I used your bathroom, I guarantee you I looked in your medicine cabinet. And if you had it in there, which a lot of people do, because you go to the dentist or you go to the doctor and they write you 90 and you need 3, you put the other 87 back in your medicine cabinet. So one of the earliest sources were medicine cabinets. And then from there, other friends of mine who are doctors. And there's a saying in recovery that we don't regret the past or wish to shut the door on it. And for the most part, that's true because it made me what I am today. This one I'd like to have back.
Okay.
I would hit my friends up for prescriptions, and they all knew me, and I wasn't a mean guy. And, they know that I'm a doctor, and surely he doesn't have a problem with this. He knows what he's doing, which couldn't be further from the truth. And so I would just hit up multiple people for prescriptions and my own form of doctor shopping. And, that continued all the way until I got into recovery.
I understand that alcohol and substance abuse is something that others in your family have experienced too. How do you think that affected your own issues?
Well, back then I understood nothing about addiction, and I'm really jealous now because there's addiction training programs out there that unfortunately I'm a little too old to go back to. We have some really good ones here in Middle Tennessee and Nashville, and one in particular Vanderbilt. But I didn't understand the role of genetics. I didn't understand the role of trauma. And so if you look at addiction, I teach it as a slot machine. When the 3 sevens come down on the pay line, that's when the money comes out. So the first 7 is the biology, it's the genetics. Mom, dad, brother, sister, first or second degree relatives, aunts, uncles, any family history of addiction. If it is, your first 7 is in the pay line. The second 7 is trauma, physical, sexual, emotional abuse, a lot of times childhood, but sometimes as an adult. And so I have a history of physical and sexual abuse as a child. And so I'm sitting there, no matter that I've got MD on the wall, no matter all the stuff, that I've done in my life, I'm sitting there with a genetic predisposition and a trauma past. And now I'm waiting on the third 7 is a social opportunity. And the social opportunity is in the glove box of my truck. And so at the time that happened, I had no idea about any of that.
That's something interesting that you say with, the genetics, the childhood trauma, and the social opportunity being something different for you being a doctor. I can imagine someone who didn't have the privilege of that.
Oh, absolutely. So if you look at me, Khalil, I never used anything other than pain pills. I didn't have to, right? I had sources. I'm a doctor. I have resources. If worse comes to worse, I could buy it. Mm-hmm. Okay? Think about not having those resources. Pain pills are $1 a milligram on the street. So if I'm using 500 milligrams a day, that's $500 a day, right? That's tough. Heroin is $10 or $11 a point. And so instead of $500, I need 4 or 5 points, so I need $50. So economics shifts this right off the bat just based on opportunity. And the real opportunity difference for me was access to quality treatment. And so when you and I sit here and we're having the conversation that we're having, and I love it, I also bleed inside a little bit every time because I know that the vast majority of people out there are never going to have the opportunity to get the quality treatment that I did. And that's tough.
You know, you spoke about childhood trauma and its relation to substance use disorder. You know, is this really something that should have increased areas of study?
Absolutely. The ACEs study, Adverse Childhood Experiences, I always tell people I think it's the second most important study ever done in the history of medicine, behind hand washing, okay? And the reason I say that is because I can't think of anything else that affects more people. Because we know from looking at ACEs score, Adverse Childhood Experience, acronym for that's ACEs. So we know that looking at ACEs scores, when you get to an ACEs score of 4 on a 10-point scale, your risk for just about everything you can think of goes up. Not only mental health issues, substance use issues, diabetes, hypertension, different types of cancer. I mean, trauma plays a big role in medicine. And I don't think we have a really clear understanding of how that works. And I know for sure that we don't have an understanding of the impact we could make if we identified these traumas earlier and started to get help for these kids earlier than we do, although we've got one really nice program here in Nashville Public Schools at Fall Hamilton that's undertaking this. But yes, there is a lot more study that needs to be done. And you know this, Khalil. We can make sure that every opioid out there goes for exactly what it's supposed to. And we can cut down the supply of this. People will always be looking for something.
How does one get to a score of 4 in an ACEs study?
Right. So it's actually 10 categories. And so it's just a series of 10 questions, which you can Google. Anybody can Google it that's listened to this. Just Google ACEs and the ACEs survey. And so it looks at 10 different areas of trauma: physical, sexual, emotional abuse. And then, it's simply scored on a scale of 1 to 10 based on how you answer questions within each of those categories.
Okay, I want to ask you a little bit more about your battle with addiction. When did you realize that it had gotten really, really bad?
I had several of those moments. And one of them was actually portrayed in the Hulu series Dope Sick. I remember the day that I went from taking 1 pill at a time to 2 at a time. And I remember having 2 in my hand and knowing I'm going to take 2 rather than 1. I was still taking them by mouth then. And I remember looking in the mirror and told myself, you can't stop this. And I knew it. I remember that day as clear as a bell in 2001. I remember it so well. And that's a helpless feeling because I couldn't quit. I remember the first time I got dope sick. Dope sick is the term for withdrawals. Mm-hmm. I didn't know what it was. I mean, I knew how to pick it out off a multiple choice exam. I learned that in med school. I was experiencing it. I didn't know what it was. And I remember being sick and going home and telling my wife I thought I was coming down with the flu. And then I remember getting my hands on pain pills the next day and feeling better in about 2 seconds. And then I knew what it was. And then the day that we had a patient come in the ICU who had overdosed on less than I was taking every day. That was a tough day. I was teaching professor in medical school, so I had to, there were medical students and residents and pharmacy students and residents around me, and I made that realization as they were giving me a report on a patient we had. As a matter of fact, we were getting ready to life flight him to Vanderbilt. And I remember having to stop around and say, we got to take a break. And I walked into the bathroom at the end of the hallway, Khalil, and sat in there for about an hour and cried because I knew I couldn't stop. And I knew I was going to die.
You mentioned that you're married with children. How did what you're experiencing How did that affect your family dynamic?
Yeah. They knew something was wrong. They didn't know what, because Dad's still doing well at work, right? I'm still providing, and
the bills are still being paid.
Right.
Everybody's still getting nice Christmas and birthday gifts.
That's right. I'm a doctor, right? I mean, we live a pretty good life, and I'm coaching Little League. You know, I'm a baseball coach. And but home life stuff was falling apart. People all the time, you know, don't. This is what you don't get with addiction. When you're addicted, the thing that you're addicted to is king. Without it, you'll die. Well, that's the mindset. What would you do to save your own life right now, Khalil? You'd do anything. And so I can say my wife and my kids are the most important thing in my life. No, they weren't. If I didn't have this pill, I wasn't okay, and I couldn't have them, so I had to have that first. And so I disconnected. I isolated. Out in the world, I was fine, but when I came home, it was upstairs in my bedroom with the shades pulled, waiting on another day. And you got to remember, every night I'm withdrawing when I sleep, so I'll wake up dope sick every day. It's a miserable existence. I tell people I went to bed half the time praying that I wouldn't die because I knew how much I was taking, and the other half praying I would. And that's a tough way to live your life, and it's a tough way to be a dad, and it's a tough way to be a husband.
Who was the person who addressed this problem with you?
My wife knew something was wrong for a long time, and I used to see her at night, you know, saying her prayers, and I knew I was in them, and I knew she wondered what was wrong with me because I wasn't the guy that she married, but she didn't know. And my dad actually figured it out, and my dad and my sister. My sister and I didn't have a great relationship back then, and she had seen me at like a Walmart, and I weighed 170 pounds and looked really, really bad, and she called my dad and said, "Hey, something's wrong with Steve." And Dad started digging, and of course my nurses and everybody protected me, and it took him a long time to figure it out, but I used one day in front of him, and really clearly I thought he'd walked off, and I threw about 150 milligrams of oxycodone in my mouth with him standing right there beside me, and the next day when I got home from work, he was in my driveway, and I knew what he wanted. And he said, "Steve," he said, "you have a drug problem." And I said, "Dad, no, I'm just overworked, paying back med school loans, and we're working multiple jobs." And then he looked at me again. The second time, it wasn't a question. The second time, it was, "Hey, Steve, you have a drug problem." And he was crying, and I was crying. I said, "Dad, I'll lose everything I got." I said, "I'll lose my medical license. I'll lose my wife. I'll lose lose everything I ever worked for." And he said, he gave me the greatest reply, Khalil, that I've ever heard, because I still haven't figured out a retort for it. He said, "None of those things are going to do you any good if you're dead." And I really didn't have a comeback to that. And I wanted help. And fortunately, I'm a physician, and I got great help.
How'd you feel in that moment when your dad said that to you?
I felt like a guy out in the middle of the ocean that was drowning, and a ship showed up out of nowhere and threw him a life preserver. Now my darkest secret was out. I could breathe, and I didn't know what was going to happen, but I felt relief.
If you're just tuning in, this is Nashville, and I'm your host, Khalil Ekalona. We're talking with Dr. Stephen Loyd about his battle with substance use disorder and how that experience led him to become an advocate for harm reduction. So, when you did decide to seek help, what were your first steps?
Well, we went to see my sister that day, and she got on. This is sad. I'm a physician, right? I mean, I'm a trained physician. I'm board certified in internal medicine, and I didn't know what to do. And she Googled it and figured out that doctors in the state of Tennessee can't just go anywhere. And there's a place called the Tennessee Medical Foundation that helps doctors with substance use disorder. And they put me in contact with them, and they gave me multiple treatment centers around the country. And there was one in Nashville, which is only 4 hours from my house. And it's kind of funny looking back on it, but I was sure my wife was going to kick me out. And my best friend and college roommate, Darren Elrod, lives in Mount Juliet. And I thought, well, when I get out, Darren will let me stay with him. And so I picked the one in Nashville, and I met a guy named Chip Dodd, and he saved my life. And that's all the research that went into my treatment center. And I went there, and I went to Vanderbilt for 5 days for detox, and then spent 90 days at CPE.
You said something interesting. You said that doctors just can't go to any old treatment center.
That's right.
There's one specifically for physicians.
That's right.
Tell me about that.
There's multiples that that are allowed to treat physicians. You've heard of one from a little bit of your stomping grounds, the Betty Ford Center in Los Angeles, Hazleton in Minnesota, Talbot Recovery Campus in Atlanta, Sierra Tucson in Arizona, the Center for Professional Excellence, which at the time was here in Nashville, and there's a few more around. So, but you can't, as a licensed healthcare provider, I couldn't just walk into, a great place we have here in Nashville is Cumberland Heights. I couldn't walk in there and get treatment on my own. This was supervised by the Tennessee Medical Foundation. For me, it was a really, really good thing.
Describe the type of treatment you received.
I was afraid you were going to ask that because I'm not really sure what happened.
Oh.
No, I say that jokingly because the process that I went through, first of all, it was a detox, right? I mean, so I have to, I guess on the street it's known as jonesing, right? You're kicking it. And so I did that at Vanderbilt, at the Vanderbilt Psychiatric Hospital. And then after there, and if I can, I'll tell you about that because that's where I started to notice the disparity. There were 24 of us in that detox unit for 5 days. I was the only one out of those 24 kids that got to go somewhere for treatment after those 5 days. The rest of those kids went back to the street. There hasn't been a week in my life go by since then that I don't think of that. These are young kids here in Nashville that don't have my resources, that were simply detoxed off the drug and sent right back out into the world. And that was a day for me when I realized that I was like, oh my goodness. And so there's 2 treatment pathways in this country, and don't make any mistake about it. And so the treatment process was about, getting to the core of what was going on with me. And it's when I first started to address the trauma. I learned how to tell the truth. I learned how to get honest, and that's a really difficult thing. There's 2 types of dishonesty: omission and commission, and it's still a process now. Probably the most important thing happened is I got connected into a community of folks who had similar issues, who helped me in my walk in recovery.
How supportive was your family? What was that conversation with your wife like?
Oh, it was bad. I'm glad I don't have to do it today. She couldn't have been more supportive. I felt like a failure. I felt like I'd let her down in about every way imaginable. Had other issues in my personal life that I'd let her down on. I told her all of them. And she decided that she married me for better, for worse, and was going to stick with me, my kids, my baseball team. I couldn't have been in a better situation. My work, the president of my university, Paul Stanton, and the dean of my med school, Ron Franks, didn't fire me. Clearly, I got paid every day I was gone. Tell me somebody else out there that gets that. Our kids on the street who are struggling, how many of them have jobs that they're going to get paid the whole time they go get help? We won't even give them help for their kids, while they're in treatment. And so my environment couldn't have been better. Darren, my friend, my friends in Nashville, couldn't have been better.
Is this where you learned about harm reduction?
Yeah. It's so interesting because I had it in my head as harm reduction before I knew what harm reduction was. I'm a member of the 12-step community. So in the 12-step community, I started meeting guys and women in programs here in Nashville. One of them was DC-4. I had no idea what DC-4 was, and it's a drug court. And I started talking to them, and I got to know what that was, and I started looking around at some of the things that were happening and people trying to help others with substance use disorder, and it shaped everything about me going forward to this day, and it all started right here in Nashville in 2004.
So you believed in abstinence as a treatment.
I did.
And now you're learning more about harm reduction. Was that from this experience that you had as you were detoxing? And you said out of all these kids, you were the only one to go on to a treatment center.
You bet. It started that day. And it grew from there. And I remember one night I was laying in bed, and I sat up in bed, and I looked over at my wife, and I said, I'm an arrogant, 3-letter word, okay? Mm-hmm. And she said, yes, really quickly, maybe too quick. And she said, what are you talking about? And Khalil, I had that bright light come on that says, look at these things that you had, because I got to feeling good about myself. I've done this. How come my patients can't do what I've done? Mm-hmm. And that's when the light came on. It's like, Steve, they didn't have access to the resources that you have access to, and they're not going to. So what are we going to do about it? and I already had the basis of harm reduction billing, and then I just made an unbelievable shift, and it became my life's focus.
You know, I know recovery is a lifelong process.
Yes.
And so you moved to this space of advocacy for harm reduction, you know, as somebody who's still recovering. I'm curious, you mentioned some support, but I'm curious about the reception you really received from your peers as you stepped into this.
Oh gosh, it's been varied. I told you I'm a member of the 12-step community. I believe in the 12-step community, but the 12-step community is, for the most part, abstinence-based, and around a lot of times some of the things that we talk about in harm reduction, they're stigmatizing. And I would encourage them to look at their role in that. I had to look at my role in it, and that's me taking their inventory a little bit, but I've gotten a lot of pushback. Khalil, when I first came to Nashville back in 2015 and started talking about the things that you and I are talking about, I got kicked out of a lot of rooms. Mm-hmm. I didn't get through my presentation. I didn't get to advocate for it because people would just stop me and tell me, oh, you're trading one drug for another, you're doing this, you're encouraging this, and this is not recovery. And so it was really tough. The good thing is that a lot of people are coming around. And here's what I knew at the time as I was doing that. I knew that people would change their mind over time, but I knew it was going to take a lot of funerals. Mm-hmm. And I'd ask the citizens out there that still have that same mindset in our state, are 3,000 funerals last year enough for you? I had my enough a long time ago. How many is enough for you? And we've had some great things happen in this area. We've had moms that have lost their children to substance use disorder that have written about it in their obituaries and spoken about it publicly. I have a group of women in Williamson County that I love, that I've watched be courageous and walk through this. And Khalil, that's when we'll really start getting honest, when we can tell what's going on inside the walls of our house and share it with each other in community and relationship. And so, yes, the response has been varied. We had my med school reunion, our 20-year reunion not long ago, and I've got classmates that have gotten rich and, retired, and they're looking at me and going, Steve, what are you doing? I've never been happier in my life. And I will continue to advocate for this, and I will continue to advocate for things that keeps these kids alive.
Talking about this stigma, I've lost family members to it. Right. And like you said, if people were honest and looked closely, even at their own family, they would find that they have one or two, at least, family members who suffered as well. Right. All that being said, tell me, who are the people who are in the most dire need of harm reduction services? Marginalized.
I remember when I knew COVID was serious, and I'm so sorry, this is going to make me look bad. When they canceled the NCAA men's basketball tournament, I was like, I told my son, I said, this is serious. We got to figure out a way to get to our patients. Our patients will die because we're talking about the things I see in this building, right? We have masks, we have social distancing, we can even work from home. And Khalil, you and I can work from home. We got a place to go. How do you work from home when you don't have a place to go? And so I knew that this was going to kill a marginalized population that I was already working with in the areas of harm reduction. They don't have 3 or 4 months to go to high quality treatment. They're still trying to scrape by day to day to make a living and keep their lights on. And harm reduction benefits this population the most. And we seem to want to put up barriers to that, and I can't figure it out. I can't for the life of me figure it out, because we're talking about keeping people alive, and I, in no circumstance can I see the benefit of letting someone die.
So tell me, what does the state need to do to really step in and step up in its harm reduction efforts?
I think we're headed in that direction. Our legislature gave us some tools here, as you and I have talked about today. I think it's an overall mindset in our leaders, and I think I have seen that. There's some positions that I've been into, and I'm not exactly, in hiding. My voice is pretty well known, and people know what I believe. And so I've been put in leadership positions to lead some of our efforts in this. And so I think that's a good thing, and I need help. And I need folks out there who may have the mindset that this is the only way to do it, to open their mind a little bit and see the benefits of keeping people alive. I need our leaders to look at the things that we know work from a public health standpoint. And we know that the things that you and I talk about today work. And I need them to pay attention to that. I need them to give us the tools to be able to carry that out to citizens in our state.
I want to thank you very much for coming on to the show. I want to thank you for your unabashed candor and your honesty. Thank you so much. And thanks to you for listening to this re-air of our interview with Dr. Stephen Loyd. He's currently the Chief Medical Officer of Cedar Recovery and the Chairman of the Tennessee Opioid Abatement Council. If you or someone you know is struggling with addiction, help is available 24/7 through SAMHSA's national hotline at 1-800-662-4357. Next year, we're planning to do some extended coverage of the opioid epidemic. If you've been directly affected by opioids and would like to share your story, tweet or email us at thisisnashville@wpln.org. This is Nashville is a production of Nashville Public Radio. Today's episode was produced by our senior producer, Tasha A.F. Lemley. Our board operator is Liv Lombardi. Magnolia McKay, Elizabeth Burton, and Catherine Cece's are our multimedia producers, and Mary Mancini is our logistics coordinator. The masterminds behind our theme music are Laurent and Namir Blade. You can listen back at thisisnashville.org or wherever you get your podcasts. And the conversation doesn't end here. Tweet us at This Is Nashville, find us on Instagram, and tell us what you want from our show by filling out our quick survey online. This is Nashville. I'm Khalil Ekalona. We'll see you tomorrow, everybody. And be good to each other.